there appears to be a huge demand for understanding and accelerating the adoption of teleurology, telemedicine, and there's been a lot of theory, a lot of coding issues, or things that you should do and things that you should not do. Well, there's nothing better than someone who's actually done it to show us how to actually do it correctly and how to do it well. I have in the program today Dr. Ian Thompson III from Texas, and he has been using telemedicine for a while, and we've been trying to coordinate and connect for a long time. I'm extremely, extremely thankful that he made time for us this evening. 2 hours ahead, he's in Texas. So thank you so much, Ian, for coming on the program, and thank you for sharing what you know with us.
Sure thing. Thanks for the opportunity. I'm glad to be here.
Yeah. So first of all, tell us, how long have you been using telemedicine in urology?
It's got to be at least 1.5 to 2 years. And I think it initially kind of dabbled in it a little bit and trying to really grow with it. I sort of dabbled with it. It really came with hiring a very well experienced PA into my group that moved to the area from Alaska, actually a large group in Alaska with a lot of experience. And you don't get the opportunity to hire folks like that in a very unique situation, and wanting to be able to be flexible and working with 2 young kids and lived about 30 miles from our practice. So one way that it really allowed me to do this was to integrate her into the practice, was to have her be in my clinic a couple days a week, and then 1 day a week working from home, and really kind of slotting out telemedicine visits. So we actually had a place to build that out in that capacity, instead of something that for me it's kind of hard to do more of a hybrid when you just already have the demand to just fill your block of schedules in clinic, if you will.
With regular visits, the traditional visit, in real life visits. Okay, so you had the person who had interest or knowledge with telemedicine, and then
I kind of said, here, this is a project I've really been kind of dabbling in. Help me, like, part of me hiring you is going to be, and bringing you on, is to say, let's let you help me expand my ability to really kind of get this up and going.
Got it.
So,
and that was about a year and a half ago, and she lives about
half
an hour away.
Year and a half ago. I'm trying to think. You lose track of time. It'll be close to 2 years ago to come this summer. Yeah.
That's wonderful.
Yeah.
First of all, what type of payer for telemedicine, and also the type of patients, because everybody's always asking.
Sure. So in Texas, so it's all state by state, but in Texas, there's legislation that says there's payer parity.
We have parity as well in Arizona.
For commercial payers. So really for us, it's been a commercial payment thing only, not only, but for the most part. You can use Medicare as well, but the Medicare laws are based on where your clinic site is. So if your clinic sites are only in if they're in a very rural place, well then yes, or such, then you could do that. But I mean, I also have a satellite clinic in outreach in Laredo, which is a highly underserved area on the border, but it's a metro service area of 350,000 people or so. So it doesn't qualify, even though it's really underserved from a special, just medicine standpoint in general.
It is not recognized by Medicare as an HPSA, health professional shortage area.
Right. From a telemedicine standpoint. And I'll have to look that. There's an actual website by which you can go look, and you can type in the physical address of a location to see if it will qualify for you to be able to see Medicare patients there.
As an HPSA using telemedicine.
Correct.
Okay. So you've been using telemedicine mostly for private pay.
Mostly commercial. But you can do it for Medicare patients as an uncovered service, and you can charge them and they have to understand. I saw some of those today, but they have to know, and they pay a cash rate for it, if you will.
Got it. So it is an uncovered, so they don't even sign an ABN.
So they're right. So it's an uncovered service for them right now. Now, as of the beginning of this year, CMS gave the ability for them to for the Medicare Advantage programs to start paying for it. So I think they're letting the Advantage programs experiment with it while we before they give it to Medicare. Now, who knows what's going to happen post Corona? I mean, it may open the floodgates and they say everybody's going to do it. So
everybody's going to do it, and hopefully they can waive the crazy originating site requirements and also the need for synchronous video and audio, maybe just audio only. Wouldn't that be great?
It makes life so much easier because you're worried about sort of taking the wrong steps and at some point. And I think that's probably what has kept so many people out of the game probably for a while.
Yeah, definitely. Okay, so you've been doing it for a year and a half, mostly private payers, but you have done it for Medicare patients. But those Medicare telephone or telemedicine visits are cash pay. That you tell them that they have to pay. It's not a covered benefits. They pay cash.
Correct.
Got it.
So, and most of those people that do that are the people that live far out, and so they probably live in a place that would geographically qualify from an underserved area, but because that's not your originating clinic site, that's not your clinical site, their actual location, domicile, or whatever doesn't qualify for that. And so, if you do the math, them paying the whatever, 50 or 60 bucks, whatever it may be, is better than their time and gas for a 5-hour round trip, if you will.
Holy cow! Yeah, Texas is a big state.
Yeah. Yeah.
So what? Okay. So all right. So let's go into the Medicare visits a little bit. What type of visits are you like? For instance, the ones that you saw today, who are Medicare patients, which it's going to comprise of a lot of viewers, patient base. What type of visits did you see, and what type of visits for Medicare patients are you typically utilizing for telemedicine?
So those are probably more easy, just give it. The other thing about it being Medicare is it's a little bit more, we don't, and I'll be honest, we don't do that many Medicare. It's a very strange, because it's two reasons. A, because of the funding capacity, like so it's really a small handful. But the other thing is that the demographic is not as tech savvy as a lot more of the commercial, which tend to be a younger demographic.
Yep.
So the commercials are all, tend to be a lot easier, adept to, they have an email address, they have all the stuff that you need. And so I really use two platforms within ours.
I was going to ask you.
Yeah, one's Chiron and one's Zoom. And
really, so you have the HIPAA compliant Zoom?
I do.
Awesome. It's like $300 a month, right?
It's $200. You have to have at least a $200 a month spend with them. And I think you have to buy a year in advance, or I bought a year in advance because there's some discount or whatever with doing it.
Sure.
Or you have to commit to a year, but they want you to do that before they give you they will sign a business service agreement that gives you all of that protection and all that stuff.
Now, do you notice any difference? Now, let's geek out a little bit. Do you notice any difference when it comes to getting the HIPAA compliant Zoom versus the standard Zoom?
It's a good question, because it's been so long since I played with, when I first was trying to, I got the free version of the Zoom and
which is what we're using right now.
Oh, really? Well, awesome. So I don't think I use a lot more Zoom today than I have. I've been mostly Chiron in the past. And the reason for that is because Chiron integrates into a clinic. I use Athena for my EMR. Yeah. And so Chiron integrates directly into Athena. It will do pre-certification, if you will, of their insurance for telemedicine benefits, schedules easily in there, and it just it makes it so much more seamless.
Yeah. I've actually went through the video, their demo video, and there's integration with Athena. Unfortunately, not with my EHR, which is Oscar.
Yeah. So for that, and honestly, my office manager today, Bianca, I'll give her a shout out because she's a member of the group and chimes in here and there. She said, well, are we gonna, what are we gonna switch more to Zoom or Chiron? And I said, I think we'll know. I said, I want to do a randomized study per se, but let's, as we're doing more of this, really start studying the pros and cons of, Chiron versus Zoom, and how we, because there's more benefits for the practice one, I think Chiron from an integration standpoint.
Yeah.
To some degree, but also and the ability to collect the patient's money up front. They pretty much have to put a credit card and so forth into when they're coming onto the screen to collect their copay and everything as part of the visit through Chiron.
Yeah.
Versus Zoom, it leaves all of that stuff There's none
Yep.
of that integration. It leaves it
Yep.
on the back end for the office staff to do, but the Zoom is a lot easier for like your Medicare patient population, the older
Got it.
population that is not as tech savvy. They're not fumbling around with how do I put my credit card in there and do all this stuff and get to where I need to be. The
But
Zoom,
most, and on the other hand, the Medicare patients, most of them tend to have a secondary. So
yeah,
you don't, once you make sure that the primary and the secondary are good, generally it stays valid for a short while.
right,
And
right,
also the other thing is your telemedicine visits are not going to be, hopefully not that expensive.
correct.
So your risk is fairly low.
Yeah, and right now during this time, I'm worried less about, which is, you know, collecting and all that. I'm just trying to keep a flow and keep things kind of, you know, going into practice, and, you know, things fall where they fall, and, you know,
Got
hopefully
it.
all works out.
Got it.
But not completely, I'm not mindful of from a business standpoint. So
Sure.
we're really just trying to get people seen and getting taken care of, because I presume this will last for a little while
Yeah.
before we get to normalcy.
Awesome. Okay, so you utilize Zoom and Chiron depending on, and you're still experimenting, which is great. So thank you for sharing the
Yeah.
platform. What type of, like, say, the telemedicine visits that you saw today for your Medicare patients? What type of patients or what type of visits were they?
So the one that I remember off the top of my head was a guy that I had done a partial nephrectomy on, a couple years ago, I think, off the top of my head, and was just going through his imaging and everything. And I will say that Zoom actually is a little better because you can actually share screens easier than Chiron. I haven't figured that out, honestly, and maybe it has that ability that I don't know of. But I was trying to do that today and I couldn't do it. But Zoom, very easily, I can pull up their scan, hit share, go through the scan with the patients, all that stuff, and that it's very easy that way.
Cool.
So that guy was, great, you're doing fine, perfect in this situation. He's older, he does not need to be out, and about, keep him home. And he's doing well. Yes, sir, we're going to get your next round of imaging up in 6 months or so. And,
okay. So this is
a year, whatever it was.
This is where I have, so closing the loop, right? So you see the patient, you do the documentation, now you order a follow-up imaging and say in 6 months or a year. What happens? What happens after you say that you close the encounter and you order the CT or whatever imaging? What happens then? What logistically happens?
So then you segregate out that discharge process. So, and right now it's all in flux. So I've been having a lot of team meetings with my staff as we completely push probably 95% of what we're doing online, just to deal with what we're doing with. But essentially I tell them today, I said, normally you'd be walking out of my clinic, and I do this with my other normal telemedicine visits, but I don't do a huge number of them. But when I do is I say, I go over the plan with them. We're going to get this lab test, and so forth, and I'm going to see you back in this period of time. And what I do is I let my staff know, and then they will either take care of it later that day or the next day, because we have staggered. We're not seeing full clinics every day, so they have days to catch up administratively, and so they'll go through, just like when I do procedures and so forth. I will put a plan. I do all of my encounters and billing through Athena for my surgery schedule, my inpatient surgeries, my outpatient surgeries, and all that stuff. So I will put a plan there with any follow-up orders that need to be done before they come and see me, like after ureteroscopy and ultrasound. So I have my staff go back through those encounters and pull out what needs to be done, schedule their appointment, get the imaging scheduled or lab tests that need to be done beforehand.
Based on what you've written down for that encounter or for that surgery or post-op.
Right.
Including the telemedicine visit, you will write down or you'll enter CT to be done in 6 months.
Yeah.
And then your staff on your days that you're not in clinic, they will circle back and then follow up.
Right. And I usually put the orders in of what I want done, just so it's very clear. And so really they just, print off the orders and email those to the patient. So here's your lab order to be done in 6 months. Here's your CT scan. And usually the patient, what we do for imaging around here is let them call and schedule one of the outpatient imaging places that we use. And that's easier than my staff doing that. And they just know, we just have my staff call a week or two before their upcoming appointments to make sure that
how do you know that the patient is supposed to how does your staff know the patient is supposed to be following up with with an imaging study, and when? Does your staff contact the patient and say, here's your appointment time, this is when you need to
Correct.
follow up?
So like after the appointment, they're going to call, and I tell them they're going to call you. So my note says everything for them to do. And the ones today, I just said, you may just get emailed an appointment and it may not fit your schedule right away, but just given how things are, we're having to redo our phone systems and stuff right now to be able to route it to people's houses, to be able to deal with, the anticipated things just getting, completely shut down.
Oh, got it. You're routing your in-office phone calls to your employees' residences.
So, yeah.
Got it.
Yeah. So I'm turning, it's almost like cottage urology practice, cottage industry.
It's it's like a virtual urology office.
Exactly. Well, I think I've told you that's how my practice started.
Yeah.
I ran out of the front office of my house for the first year, which I'm sitting in right now. This was the headquarters. It's still the headquarters of Texas Urology Group.
Man, you're like so far ahead of this. No. I mean, so far beyond what I've heard of anyone doing it. You literally started your practice at home virtually.
Yes. I mean, $6,000 investment. I have a picture of my whole practice in a roller bag. The most expensive thing was a bladder scanner. Aside from that, yeah.
I love it, man. That's a topic for another podcast, another conference.
Yeah, it's a whole other thing to start up. Yeah, yeah.
Okay, so Medicare patients, you saw nephrectomy, post-nephrectomy. You went through over imaging. It's a cash pay type of a visit, and your staff collects a credit card, or is there a credit card on file? How does that work?
Yeah. They usually will go back and collect it based on the level of service. We have cash sort of things based on the level of service.
Got it. So you provide the service and then they collect afterwards.
We've been doing that more easily. I try not. It's a little more difficult for you in Athena to go settle out the claims and everything. For me, I do all my billing and stuff, my own billing.
Yeah.
But it's easier for me to do that for the commercial things, because that already I don't know how to explain it. Kind of, it will auto adjust with your fee schedule and everything. But to do that in Athena with something that's less than, or you're giving a reduction on cash, either for cash pay or something like this,
it doesn't quite match up the fee schedule. You have to do some adjustments and write-offs.
You have to do some adjustments, and that takes a lot more time on my part.
Yeah.
So I just let all of these be handled from a billing standpoint.
Smart.
With my billing sort of lead within the clinic.
Okay, so that is okay. So Medicare. What about let's go over your private payers when it comes to you having to generate the visit, and then the type of visit, and also how do you do the billing? Is it fairly similar?
So for most of my experience with that, it's just with Chiron, and so you can actually within Chiron code the visit right there.
Got it.
At the end of the visit. And if it shows based, and it kind of pre-screens and based of it, if their assessment shows that it's not as well covered automatically, then it'll say how much do you want to charge. So you can change it to charge a cash amount or based on a level visit, if you will.
And that. Got it. And oh my gosh, there's a lot of people watching. Jen, Gabrielle, Olympia, Harpreet, James, Mark, James, Brittany, Kelly. Kimberly asked, can you please share your process regarding obtaining and documenting consent? Sorry to railroad you.
So that's a thing that probably is the biggest thing to do. Like it's like very manual right now, and so we're all time looking at third-party ways to do that beforehand. So it really takes us to be able to send out a consent. So we treat it like if they're not already. It's built into the consent to begin with, so when they come in, right? But if it's not, then, and they've like a new patient that's not already established, we send them all the new patient paperwork and let them email that back to our, compliant, HIPAA compliant email, or they can just fax it back to us. And then we print that out and we upload it to our system. So it's not, there are ways to potentially do this a lot more seamlessly. We have looked at a couple of vendors and gone down that road, but we haven't sort of pulled the trigger per se. Right now, one thing I'm looking at to try to speed this up is because I'm looking at, well, long story, but is actually using like a DocuSign type thing to where you just put everything in there very clearly, initial, it dumps, and then you get back to queue. Then we can print that out and upload it to the file up to the EMR, if you will.
Yeah, for me, we have the ability to capture faxes electronically, and then we can simply electronically file it into the patient's chart once we create the account. And I think Kimberly may be asking the type, how do you obtain consent maybe for the telemedicine visit? And I think, Kimberly, that will be a verbal consent, and you would simply using a dot phrase or auto replace text in the encounter note saying that I verbally obtained consent for this telemedicine visit and blah, blah, blah.
Right. Yeah. And you can do that. And there's most language, to my understanding from legal. Now, I'm not a legal expert, so I always recommend, but that for sure, from my understanding, suffices as well. And right now, at least in Texas, just a phone consent. Right now, you can establish the doctor-patient relationship via phone in Texas right now, and that's enough.
And you're talking doctor-patient relationship for both an established patient and a new patient visit.
Right now in Texas, you can do that.
Okay.
As part of the declaration, the state of emergency, from what I understand.
From coronavirus, because of this. Okay, so who knows how long this lasts and if it'll continue.
What does it fall back to? I don't know.
Okay. All right. Sorry, I interrupted you regarding the new patient. So I'm sorry, the private pay non-Medicare patient, shall we say?
Yeah.
And so you see both new and established, or do you see mostly established?
So mostly established, but there are some news. Mostly it would just be those, obviously the commercial pays that we can do that. Now everything is state by state, and so they have to be regulated so they have to be seen by another physician for that same issue to be referred to you for specialty consideration.
So this is a new patient. This is a private payer new patient. You require that the patient has been seen by another physician, like a referring doctor, for that issue, and then the patient is being referred to you for that issue.
Yes, exactly.
Got it.
So an example is, I get a call from one of my ER docs for an obstructing ureteral stone in the ER, and they call me, and I don't have a slot in my clinic. Well, we can see them, so if we can get them so they fill out the paperwork, get them to us, then we can see them in our clinic and get them set up that way. So kind of get the ball rolling for there. I've even had it to where I've not been there, and and we see them and get them set up for a stent, if you will, without having to bring them back to another emergency room visit or even into clinic. Can just bring them straight into the hospital to do the stent that day, if you will, in a couple instances.
Okay. So hang on. So a new patient, maybe an ER doctor calls you, says there's an obstructing stone, and refers the patient to you. You never physically see the patient, but you reviewed the records, and
they send me imaging. I can access to imaging from afar, can see their imaging, talk, go over that, see the patient through a telemedicine visit, say these are your options, and if you can tell right there, and you can tell somebody, you don't need to physically see them if somebody's really dealing with a bad obstructing stone. Say, okay, here's options. We can, medical expulsive therapy, like you would normally do, spend the 2 weeks waiting to get into my clinic, or, hey, uncle, let me go get a stent and, get relief, or, if you want to do something, treat the stone at the time, if you will. So,
nice. Wow. Yeah. Okay.
We've done that a couple times, and it's, but it doesn't always work. It's more of a logistics game than it is anything else.
Yeah. When do you schedule that patient to be seen in your day after you've seen your patient's IRL, and when do you schedule that time face-to-face video conference with that ER stone patient? Or
it's usually kind of like end of day or first thing, kind of things have to line up to do that, but it's like, can you build in the right bandwidth within your organization to do kind of do that stuff?
Yeah. And do you use Chiron for that mostly? You said most Chiron for private pay?
Yeah, I do. Yeah, I do that for Chiron for private pay. We have plans to use more Zoom in the more hospital setting
Yeah.
type things, because you don't really have outpatient billing. I mean, it's a whole different thing
Yeah.
for consultations, and so that's another thing. So
How do these patients, like say for instance, this new patient you've never seen who was you're being consulted through the ER, this patient with a stone, how do you let the patient know, okay, this is where you need to click to sign in to Chiron?
oh, so my office does all that stuff of gets them
Okay,
on the phone, so it's all about, it's the registration process is all the same as you'd book them into your normal clinic.
got it, got it,
And so we forward email with, and there's all this, and Athena has it built into the schedule. Like, we're going to schedule you a visit in Athena, then it's going to push all this information out by
got it,
email on how to do it.
got it. So
Um,
the patient has to be somewhat sophisticated and well connected with the digital platform of some sort.
yeah, and I spent a lot of my time today calling my staff. Can you call them and tell them to, because a lot of the patients, they weren't scheduled telemedicine up until last Thursday or Friday when we started making this shift to this direction. So
Wow.
a lot of there are some that will just prefer to see you on telemedicine all the time, and once they kind of get the hang of it, and then others that it's going to be a little. I know it's going to be a little more clunky over the next couple weeks for us, a
Wow.
few weeks.
I can't wait to visit back with you and have you share some
Yeah,
best practices when it comes to workflow.
yeah, yeah. Hopefully, we'll have worked a little bit of it out by then. So
So that's a special case, and you said it's not frequently that you do this new patient ER consult. What are some of the
yeah.
most typical follow-ups of a private payer in your office for telemedicine?
Right. So, like, classic, that stone patient that you've treated and you've done the uteroscopy, for instance. I follow mine up with an ultrasound about 6 weeks out after their uteroscopy and after their stent has come out. So perfect is, I treat their stone, leave a stent with a string on. They have instructions to pull it out several days later at home. They get an appointment in 6 weeks with my physician assistant via telemedicine, with a preclinic ultrasound to be done a week beforehand, more or less. And we'll have the stone analysis results by then. We'll have the ultrasound results, make sure everything looks good. We'll talk about stone prevention during that visit, what have you. We'll talk about options. If you're a recurrent stone former, do you want to, proceed with metabolic workup? Do you want to work on behavioral modifications and then see where we are? Set up the next follow-up visit in the future, kind of thing. So that's like a classic great thing. So when I get done with doing that uteroscopy case, I in that flow in the plan, I say follow it with with
It's
the
templated.
Felton, yeah, and then with this ultrasound and that, and so that's perfect, and that fits so well into people's work life. When you really get in the hang of it, you're like, man, they can just, and you see patients can just step out from work on their phone and have that visit, or they're not having to take, because sometimes you're running behind, which is invariably, at least in my clinic, sometimes, probably not as efficient as you, but is that you be considerate of the time value of money, if you will, for other people. And so I think we'll see more and more demand for this.
Yeah, once we as urologists become comfortable, I think you start saying, "Hey, this is the way to go," and patients start using it, and they're like, "Man, why didn't we do this sooner?"
Yeah, yeah.
And I think
So
what you said with the workflow, the templated workflow for that, you after that post ureteroscopy, you simply push that protocol out, and your staff, because you've done it so many times, they know what to expect,
yeah,
and
yeah.
it's like a knee jerk response.
Right. And so it's easy. So and I still tailor that to who the patient is, kind of where they're coming from and their sort of level of sophistication. So you kind of have to know that. And a lot of it comes to scripting beforehand from the doc, so that you say, you know what, I'm going to have you see my PA by a telemed visit. But I also do that in my own regular clinic visits. Say like, hey, we're going to start this, and we're going to do your next visit's going to be in with a
It's no different than if you have an APP and you see the patient initially as a new patient, and you tell the patient, "Hey, the next visit is going to be with my APP Sarah, and
yeah.
don't be surprised. And similarly, what you're saying is that, hey, the next visit, it's going to be a virtual visit. It's going to be a telemedicine visit. So don't be surprised and expect that.
Exactly. And you just brought
Awesome.
up something that jogged my memory. Chiron has these posters and stuff to put in your clinic. So we've got
Oh,
them in every room, just because I'm sure like you have, hey, ask me about Urolift kind of brochures and stuff around your office. And so that works, because they'll be like, hey, doc, what is that about? And then it gives you an opportunity to spend a second and tell them about it and say, hey, let me have my staff, when you're walking them out to the discharge, the next visit, we could do in clinic, or we can do in as a telemed visit just fine. And whatever works best for you, my staff will accommodate that.
yeah. I actually have already built into my assessment and plan under the follow-up section, virtual visit. And I pre-templated like virtual visit in 1 week, 2 weeks, 3 weeks, 2 months,
Yeah.
3 months, etc. So that's all ready to go.
Perfect.
Yeah.
Perfect.
Let's see who else has questions. Kimberly Olympia says, what CPT do you bill for a new patient? 9942. Yes, Olympia, it'll be for this. So Olympia, it'll be a new patient, like a 9920 something.
Right.
It'll be a
Right. So
9920 something.
and I mean, you're not going to, for the most part, be billing any level 5s or anything, unless you're just sitting on there for, from a time standpoint.
Yeah, billing by time.
Yeah. And so I do usually 99203 for a new patient visit for most of them. Sometimes it's 04, it just depends. But I think the routine telemed visits will probably be more 3s and 4s. Probably lean a little bit more to the 3s, if you will. One thing I don't know if I sent to you, kind of alluded, is that I think it depends on the patient. I used to think that it always cuts down in time normally, because you lose a lot of the, hey, how you doing? All these pleasantries kind of stuff that kind of naturally come in an interpersonal connection, like, I feel like. And so when you start the telemed visit, you're kind of almost more down to business kind of stuff, of the nature of the visit, what's going on, where are we going from here, kind of thing.
Nice.
And so when I look at, Chiron's nice because it times the video visit. That's one thing. So if you're thinking about billing from a time standpoint, it's all built into, just like when you're at your lawyer's office, if you ever pay attention, most of them have something on their computer screen that's billing, so you're active. They're watching the minutes. But on Zoom doesn't really have that. I haven't seen that capacity that's already there.
Yeah,
so.
I'm running Zoom right now in our visit, and there's no timer.
Yeah.
No, there's no. But on the software that I'm using to stream to Facebook, there is a timer.
Yeah.
It tells me that I've been live for 34 minutes. Okay.
Oh wow.
Yeah, time flies when you're having fun, and the lawyers
exactly.
definitely track by time. When I used to, I did computer consulting before medical school, and lawyers were my clients. I billed them in 6-minute increments, so the time value of money and opportunity cost is never lost on me.
Yeah. Like you said, like you showed that the other day with the lawyer bill. They're very cognizant of it, for sure.
Okay, so that's a great summary of what you do. We talked about Medicare patients, which you in general bill cash, and then for private payers you bill with a 9921X or 9920X. With
the GT, what I'm doing, you can tell me, I haven't watched your interview
with the GT modifier and the place of service
GT
too.
Modifier, yeah, that's what I put.
GT modifier, and do you use place of service too?
I have to go back and look and see. So
maybe Chiron does it automatically for you anyway.
Yeah. And I have to go back and check.
And your biller may bill place of service too. But I think for everybody, you all have to just play it by ear. Some payers will want GT. Some payers may want 95 as a modifier, and some payers may want place of service too, or who knows.
Yeah.
So you're just gonna have to play around with it and share what works in your area so that other people can hopefully benefit. Just like what Dr. Thompson is doing, sharing his experience with virtual visits.
Yeah. So So I think it's probably, like you say, just run the reports and kind of see if you're getting paid or not. And then, it's probably a little bit of investing and see what works and what doesn't work. That's kind of thing, the
Man,
approach.
man, this is great. Like practical tips on how to implement telemedicine, teleurology.
Yeah.
Let me
So,
see. Does anybody have any other questions? No, I don't see it. Well, obviously, if you have any questions, certainly leave it in the comments. And Dr. Thompson is part of the Thriving Urology Practice Facebook group, so I'm sure he will. Oh, wait. Kimberly, can you please share your estimate ratio of level 2, 3, and 4 for established patient virtual visits? That's a good question.
I think the vast majority are level 3.
Vast majority are level 3 established. Okay, great.
Correct. I think so. Yeah, very rarely are they level 2, and that's probably the least. And the 4s are more just on a documentation of time kind of thing. But I think level 3 is probably 80 to 90. Somebody put a question out there, and I tried to run it the other day for a period of time, and I just don't have the numbers in front of me, but the vast majority are level 3s.
Well, for an established patient, so if you're seeing established patients, if you you have you have 2 established problems and you're prescribing a medication, that's a 99214.
Right.
If you fulfill all the criteria for the history section, and hopefully that's been captured by your medical assistant beforehand, or you can do it yourself. But that if you have 2 established problems and you're prescribing a medication, that's a 214, according to the current E&M guidelines. Now things are changing in 2021, so stay tuned. But for now, two established problems that you're managing, like BPH and then ED, and you're prescribing like renewing an ED medication or continuing an ED medication, that's a 214, provided that there's medical necessity and you are documenting appropriate level for your history section.
Right. Yeah. So I will tell you, you're probably right. I might be able to be doing more 4s. I think we historically have done a little more 3s. But I think you can you could do more 4s if you're really paying attention to it as you go.
Yeah, definitely. Well, understanding the coding rules.
Yeah.
All right. Well, I see. Well, hang on a second. Oh my gosh. James, Kimberly says, thanks. James, Dr. Seifert says, thank you. Dr. Seifert says, can we bill Medicare now with the current situation? Dr. Seifert, you've been able to do Medicare. You've been able to bill Medicare now. With the
well,
current
you can't
situation.
bill Medicare direct. I've not practiced in a place where you can bill directly to Medicare for this. Now, I would say I'm tempted in this current. Well, who knows? If CMS is going to come out and say we're going to give a temporary, relief of this and do that. So one way to maybe do this is if you've got a bunch of Medicare patients, and I don't know if this is just me off the cuff saying, well, you just do the visits, hold the claims, and see what happens.
Yeah.
Kind of like, and see, because they're one that will, like, when you're first starting a practice, once you get your once you apply, you can start seeing Medicare patients, and then you just wait for your approval, and then you can drop your claims and get paid retroactively from when you apply in Medicare.
Well, I don't know. I don't know about that, because it may, depending on your date of service instead of the submission date. So
yes.
Anyway,
maybe I need to go back. It's been a few years since I started, but I'm trying to think about when I started. But anyway, so if you wanted to experiment, I don't know.
Yeah.
So at this point, I think it's more just about taking care of the patients, honestly, during this period of time.
Yeah. So for Dr. Seifert, you can bill Medicare for telemedicine, and you may want to look at the video that I did with Mark Painter this morning. Dr. Seifert, it covers under what circumstances, given the current rules, not the coronavirus notwithstanding, given the current rules, you can bill Medicare for telemedicine visits, but it's kind of onerous, and there are a lot of restrictions. Then there are telehealth codes, the G2012 and G2010. Those are telehealth codes that are typically patient initiated. And then there are the 99421, 422, and 423. These are digital evaluation and management services for an established patient and it's actually cumulative 7-day time that you spend taking care of the patient. So that's another form of telemedicine visit. It is not really quite applicable to what we are trying to deal with in the era of coronavirus. So I think yes, there are ways to bill for Medicare visits, but it's not what we want to talk about.
We've recently tried a couple of the G codes. I have to go back in. I haven't gone to look to see if they've actually, been paid for or not. But just because we know that we're doing the work regardless.
Yeah.
For those the visits, and so we've been sort of trying with that and see. That's a good thing. I got to go back and check to see that.
Yeah, it's a lot of requirements, right? It has to be patient initiated. It's got to be something that you didn't cover over the last 7 days, and patient can't be seen for the next available appointment, and all sorts of usual BS from Medicare that you have to adhere to. And we're hoping that because of the emergency declaration and coronavirus, that some of this will go away, but I don't see it happening yet.
I'm holding my breath right now.
Yeah, so maybe if it does go away, they need to be absolutely clear on how we can do it and what's applicable. But like you said, Ian, you can do it right now to take care of the patient so that the vulnerable does not have to come in for their office visit.
Yeah, and I think that's
or the other thing you can do is just do it and just document it and not even bill for it.
You can always do that.
Not ideal.
Right. Not ideal, but I mean, because we're all looking. I mean, for all of us that are in small business, urology or all physician practices, the prospect of surgeries being canceled and so forth. You're just trying to. I've already, how do you plan for just keeping your practice afloat during this period of time? So I encourage everybody to sort of see what they can do and integrating the technology and I think, like as I mentioned before, this is going to be a real accelerator and transformational time, I think, for the delivery of healthcare.
Yeah, nothing like a crisis to kind of fuel the acceleration of a technology that should have been adopted and implemented a long time ago.
Right, exactly.
All right. Anything else that you'd like to add before we end?
No, I mean, this is a great group. Thanks for putting it together. I learned so much and love to hear what people are doing all around the country. And I really appreciate the opportunity to share here. And if anybody's got any more specific questions, feel free to reach out to me. I'm always happy to chat.
Okay. So thank you so much. I know we try to connect over several weeks.
Sorry.
Literally.
Yeah. It's like I always get pulled in with all the COVID kind of stuff going on crazy with hospital work and so forth.
You've got your primary gig, which is urology, and then you've got your CMO, like you're the chief medical officer of your hospital, and you also have some sort of a physician job placement thing that you do, your side gig.
I have urologylocums.com is a site, is a business I run. I have a full-time recruiting staff that placing urologists and urology locums gigs specifically. And then when I was a resident, I started urologyjobsearch.com. So that's more for just connecting employers to job seekers without sort of the third-party recruiters. So if you're looking for a urologist, like I'm always recruiting. So if you know anybody that wants to come to San Antonio, please give them my name. But that you can post those jobs on there for very affordably and try to draw job seekers and stuff and make those connections.
Great. Cheaply. I'll put those in the video description as well. So thank you so much,
awesome.
Ian.
Cool. Thanks so much. Have a great night.
Okay. And for those of you who are jumping on late, definitely play it from the beginning. Ian dropped some amazing nuggets of information regarding how he sees his telemedicine visits for both Medicare and private payers. Thank you all so much for watching. I know for some of you it's late at night, and hope you are all doing well. Stay safe, wash your hands, and practice social distancing. Bye-bye.